Thank you, Maggie and Shahed, very much. Thank you also for your leadership in this area. I mean, it is, as both of you have said, incredibly important. And despite everything else going on in public health, not just in the immediate context of the pandemic, but actually just over the last few years, there have been many changes in priorities in relation to public health, but cardiovascular disease has remained a high priority and should remain a high priority. And I think you're doing absolutely the right thing with this seminar to remind us all of that. My task is to introduce the topic with a little bit of epidemiology. And I'm going to do that also by introducing you to the sorts of results you can get from the Global Burden of Disease tool, the GBD Compare tool. And I'll give you some results, but I'd also encourage you to have a look at it yourself. But I'll say a little bit more about that later. I think I should be able to move my own slides now. And I should also say thank you very much to all those of you who are joining us. I know it's been tremendous to get this level of support. Everyone's incredibly busy at the moment. We really appreciate the fact that you're giving up your time to join us at this webinar. We look forward to your comments and questions and feedback. So thank you very much to all of you. So cardiovascular disease, no, sorry, I just need to get, I think I have control of my slides, but yes, there we are. So cardiovascular disease, of course, has improved a lot. I mean, if we take, say, the period of from 2001, there have been enormous improvements in mortality from cardiovascular disease, and that's fed through into improvements in life expectancy overall. But it's still an incredibly common cause of death. So 1 in 4 deaths in England are due to cardiovascular disease. So that's including ischemic heart disease and stroke. 1 death every 4 minutes. As Maggie has said, unfortunately, cardiovascular disease remains one of those conditions which is very patterned and by social class and by deprivation. And therefore, we do see substantial inequalities. So there are twofold variations by decile of deprivation due to cardiovascular disease, and we're talking there about under 75 mortality. So premature mortality, there's a twofold variation by decile. But if you look at smaller areas, local authority areas, it's even greater. So it's 4 times, there is a 4-fold variation, again, in premature mortality across the country. And if we look at the UK, it's places like central Glasgow that have the highest rates, and within England, places such as Blackpool and Manchester often stand out. But this sort of variation is actually present all over the country. I was Director of Public Health, Regional Director in the South East, and we had really quite profound differences in cardiovascular disease rates, even within some of the large local authorities like Hampshire. So this inequality is a country-wide issue. And of course, as Shahid mentioned, there's also other aspects of inequality in relation to cardiovascular disease. It's more common in men than women. It's more common in people with severe mental illness, and it's more common in people with South Asian and African, Caribbean ethnic background. And then moving on to blood pressure as a risk factor for cardiovascular disease, and I'm going to talk mainly about blood pressure in this talk. Blood pressure is perhaps more common than people realize. I mean, 1 in 4 adults in England are affected by higher blood pressure. And that, of course, varies again around the country. So in some more deprived areas of the country, that can be 30% higher than that. Blood pressure is an important risk factor, makes a very significant contribution to overall mortality and particularly to cardiovascular disease mortality. And I'll talk more about that in relation to the global burden of disease in a moment. But we are talking here about almost half of heart attacks and strokes being attributable to raised blood pressure. And this is a huge number, and it's a preventable condition. So this is really, I mean, this really should send alarm bells ringing for public health. This is something which we know what we can do about, and is causing an enormous burden at the moment. And that really is, I think, going to be the main message from this seminar. I look forward to hearing from from others on this theme. But as I say, back to the epidemiology. I was going to talk about the global burden of disease study. Now, many of you will know something about it. Some of you may know a lot about it. It started back in 1996. It was an idea. It started by Chris Murray and Alan Lopez, and amazingly, both of them are still heavily involved in it. They're remarkable epidemiologists, and it's an extraordinary contribution over a very long period. To begin with, it was a rather limited project. It was funded by World Bank and WHO, and they have gradually improved it. There was a step change in, it's gone through various iterations, and towards the end of the last century, it was re-established in University of Washington, funded by Gates Foundation, and in actually, no, I'm sorry. It was later. It was about 2007, 2008. I think we moved to Washington. So the landmark publication was in 2012, which was the new version of the Global Burden of Disease, published in the Lancet, and it was a much more comprehensive approach to integrating risk factors and outcomes into this framework model. And ever since then, there've been a remarkable series of publications. Many of them in the Lancet, but there's a lot published on the IHME website, exploring the richness of these data sources. So what's the point? The point about global burden disease was really brilliantly summarized, I think, by my colleague Alan Davis here, who used to work with us in Public Health England and is still involved in GBD, although now retired. And he encapsulated the point about GBD is that it looks at everything all at the same time and tries to understand how all these different risks and different diseases come together to affect the picture of health and ill health that we see around us. And of course, this is incredibly meaningful. It's meaningful for individuals. We want to know about our whole health. We don't just want to know about one organ system. And it's meaningful for populations. We need to know, if you're a policymaker, you need to know about all the different conditions that cause mortality, morbidity, so that you can make the right balanced decisions about how to use your resources. So GBD is an incredibly challenging thing to do from an epidemiological point of view, but incredibly useful as well. And what it does is to integrate data which describes premature mortality together with data that describes the loss of health while people are still alive, and uses the most sophisticated available, often Bayesian modeling techniques to try and estimate these effects, even where really good data aren't available. So it takes the data that we do have and it makes Bayesian type assumptions about the data that we don't have, and the whole thing is continually iterated to try and get the best possible estimates. And it's almost every result from the GBD is wrong, but the point is that it's as right as it can be. So they are good estimates for a fairly high level decision making. You have to be a little bit. There are a number of health warnings if you start using individual results too carefully, but we can get on. Nevertheless, I think we'll all agree that it's an incredibly powerful public health tool. So moving on then to some results from the GBD. So we have I've summarized them here, and then I'll show you a few slides. So the main thing is we're talking about cardiovascular disease as a whole. It is the second largest cause of burden, and that's including mortality and morbidity, second only to cancer for England. But of course, when you look at non-fatal illness, it drops down. So most of the impact that cardiovascular disease has on the DALY figure, the overall health figure, is through early mortality. That overall burden, as I mentioned earlier, has reduced considerably. I mean, there really have been phenomenal gains in terms of cardiovascular disease burden, but that's mainly been for ischemic heart disease and stroke. We've seen no such improvement for atrial fibrillation and for peripheral arterial disease. There have been improvements for burden due to aortic aneurysm, which presumably is due to the screening program. Moving on to blood pressure, blood pressure is by far and away the top risk, attributable risk for overall cardiovascular disease burden for both ischemic heart disease and stroke. And it's, in terms of overall burden from all causes, it's fifth. Now, it was second. As recently as 1990, blood pressure was the second highest overall risk, and it's dropped down to fifth. But that's not because blood pressure has gone away. It's because the total burden of cardiovascular disease has decreased. And I will come back again to, I'll show you a bit more detail about the attributable risk data. And then if we look at cardiovascular disease overall, and we look at the amount of cardiovascular disease attributable to blood pressure, it's just under half. So what that means is that every year in England, there are 65,000 deaths occurring due to high blood pressure, which could be reduced if we could reduce the impact of high blood pressure. This is a phenomenal burden of preventable early mortality. So these are the sorts of outputs you can find in GBD. So I say, if you go onto the web, you can do a simple search for GBD compare, and that gives you access to this tool, and you can play with it in many ways. I think it's fairly intuitive, and I'm sure you'll soon get the hang of it. This shows overall burden, so this is DALYs, so all ages, both sexes. And you can see in the top left corner, there's cardiovascular disease broken down into ischemic heart disease and stroke. And it's just slightly different for men and women. So for men, that box is 16% of the total disability adjusted life years, due to cardiovascular disease. If you look not at DALYs, but at YLL, so early mortality, that proportion rises to 27% of YLLs for men. And the other thing you can do with this slide is you can click on it and you can look at the extent to which that burden can be attributed to different risk factors. And for cardiovascular disease, that's 84% for men. So that means that's one of the highest proportions of any condition which has an established evidence base for attributable risk. So it compares, for example, to about 50% for all cancers. So put another way, you could say that 84% of the burden from cardiovascular disease for men is potentially preventable, because nearly all of those risk factors are at least potentially preventable. And if you take just blood pressure in the GBD model for men in England for premature mortality, 48% of that burden of premature mortality is due to blood pressure. For women, the figures are slightly lower. So overall, it's 12.5% for total burden due to cardiovascular disease for women, but it's 24% of premature mortality for women due to in cardiovascular disease. So 24% of premature mortality is due to cardiovascular disease, of which 76% is attributable to, is potentially preventable, and 42% is attributable to blood pressure. So it just puts some numbers on the high level finding, which is that cardiovascular disease is a huge contributor to overall mortality. Blood pressure accounts for almost half of all cardiovascular disease burden, and a great deal of the rest of cardiovascular disease is also preventable if we could only get people improving diets and reducing smoking and a little bit more physical activity. There was very good evidence that this would make a big difference. So moving on then to one or two of the other sort of outputs you can get. This shows a change over time in the DALYs, so total burden for both sexes, all ages in England over time from 1990 to 2019. So the top, the dark area at the top is ischemic heart disease, and then we've got stroke, and then we've got the other cardiovascular diseases. So you can see this enormous reduction in the burden due to ischemic heart disease, possibly a suggestion of a hockey stick, which is a bit worrying, that that trend certainly has leveled off and may even be increasing. And then looking more specifically at the attributable risks, so these again are the sorts of outputs you can get showing what amount of disease is caused by or attributable to risk factors, and you can see so this is for cardiovascular disease alone. High blood pressure is by far the biggest. You can't add all these up. There is a rather complicated methodology that allows for the fact that some of these risk factors work in a pathway. So one of the ways in which high body mass index causes cardiovascular disease is through blood pressure, for example. So some of them are mediators, but that is dealt with in the model. And you can see at the top that blood pressure causes all kinds, the full range of cardiovascular disease outcomes. And the slide below is for women, showing similar pattern, but slightly smaller overall effect. And so I've mentioned, so of total YLL, so this is for cardiovascular disease, but you can do the same for all conditions. For men, 13.5% of all adverse outcomes of premature mortality are attributable to blood pressure. And of that 13.5%, 13% is through its impact on cardiovascular disease, and the 0.5% is through chronic kidney disease. So those are the two big ones. And for women, the numbers are similar, but slightly smaller. It's 10.5%. So again, 10% for cardiovascular disease, 5% for chronic kidney disease. And if we're looking at, again, overall, the importance of high blood pressure as a risk factor, then for premature mortality, high blood pressure is the second biggest contributor, second only after smoking. And for overall mortality, overall burden, it is the fifth. For YLDs, for disability, ignoring impact on premature mortality, it actually drops down to the ninth. So I think we shouldn't ignore that. High blood pressure does cause disability, mostly through the impact on stroke and chronic kidney disease, but it's a much smaller effect than its effect on mortality. So this is just a little bit more detail on local authority. We're in a very strong position with the global burden of disease. For many years, we've had a collaboration going with the University of Washington, and they produce estimates by individual local authorities. So on the GBD Compare website, you can find local authority data. This shows the attributable risks for premature mortality, years of life lost, for individual local authorities. This is from the paper we published in 2018 in the Lancet, so it's data up to 2016, but the more accurate, more recent data is available. And it shows the attributable effect of different risk factors. We've got 9 different risk factors in each local authority, and we have high blood pressure is up in the top right-hand corner, and the local authorities are ranked according to the deprivation, so the IMD score. And the first thing just to mention is that the y-axis is different in each case. So for tobacco, it goes up to 3,500. These are age standardized YLLs. Whereas for high blood pressure, it's only 1,500. So they are there are different effects. But what you see very strikingly is the pattern by deprivation with local authorities, and one might guess that someone like Manchester or Blackpool might be up here in the top right-hand corner, have much higher burdens due to all these risk factors, but high blood pressure is particularly marked. And although most local authorities sit on the diagonal axis, there is quite a spread. And the colours represent different regions. So we have the orange colours are the northwest, the grey are the southwest, and the blue are for London. There's a general effect that London does rather better than you'd expect. So there is something a little bit more than just the deprivation effect going on to explain individual variation. But hopefully these data are useful to people working at local level, and we know that people use them fairly extensively, and be interesting to get any feedback on them. But the effect really is striking in terms of showing the impact of deprivation. And of course, variation in attributable risk is a combination of 2 factors. It's variation in risk, so there might be more smoking or there might be more high blood pressure, but one of the other drivers is the amount of disease. So if there's more cardiovascular disease, the attributable risk will be higher, even if the risk level is not increased. And that's illustrated in my next slide, which shows this is just the burden of cardiovascular disease deaths. So deaths per 100,000 in different regions of England, and you can see that London is a lot lower than the rest, and therefore the number of deaths due to blood pressure will be less as well in London, just because the overall number of deaths differs. So that's a flavour of what the GBD can show you. I'd encourage you to go and have a look at the data yourselves and to explore it and draw out the story yourself. There's a huge amount of information there, but it's a great lead into the rest of the seminar, I hope. We know that treating blood pressure reduces cardiovascular risk. Every 10 millimeter reduction saves 20% of the risk of cardiovascular disease. We know that 4 out of 10 people with hypertension are not fully treated. We have set ambitions to improve that. Currently, we think we detected around 57%. High-performing public health systems like Canada detect 80%. We know we don't manage all our hypertensions effectively. We could manage 80% better. I think the epidemiology has shown that if we could achieve these ambitions, the impact would be enormous. Thank you very much.